Welcome to this presentation on multimodal approaches to pain management in dogs and cats, where we explore how to enhance the quality of life through effective pain management strategies. Pain management is crucial for the well-being of our animal patients. It significantly affects their welfare, behavior, and recovery. Proper pain control not only improves the health of the animal, but also strengthens the trust and satisfaction of clients. A multimodal approach to pain management involves combining various pain-relieving techniques that act through different mechanisms. This integration of pharmacologic and non-pharmacologic therapies creates a synergistic effect, providing superior pain relief compared to relying on a single method. Pain can be classified into two main types, acute and chronic. Acute pain is sudden and intense, often resulting from surgery, trauma, or injury. Chronic pain, on the other hand, is persistent and ongoing, such as in cases of osteoarthritis or cancer-related pain. Understanding the pathways of pain is essential for targeting effective treatment strategies. Multimodal approaches aim to address pain at multiple levels, providing comprehensive relief. Pain starts when nociceptors, specialized receptors for noxious stimuli, generate electrical signals. These signals travel along two types of nerve fibers: A delta fibers, which carry sharp, acute pain quickly, and C fibers, which transmit dull, throbbing pain more slowly. Once the signals reach the spinal cord, they enter the dorsal horn, where they can be modulated before continuing along the spinothalamic tract to the brain. The thalamus acts as a relay station, directing the signals to the somatosensory cortex, where pain is consciously perceived and processed. This intricate journey allows the body to detect, interpret, and respond to harmful stimuli. Pain signals can be modulated at various points along their pathway. Initially, at the site of injury, nociceptors can be affected by local analgesics like NSAIDs, which inhibit pain-causing chemicals, or by local anesthetics, which block ion channels and prevent signal generation. In the spinal cord's dorsal horn, pain transmission can be regulated by endogenous opioids and inhibitory neurotransmitters like GABA, which dampen the signals. Additionally, descending pathways from the brain can modulate the spinothalamic tract, using neurotransmitters such as serotonin to reduce the signal intensity. Finally, in the thalamus and somatosensory cortex, pain perception can be influenced by various interventions, including cognitive, emotional factors, which alter how the brain processes and responds to pain. Pharmacologic methods include NSAIDs, opioids, antidepressants, and anti-epileptics. Nerve blocks, such as perineural and central neuraxial blocks, offer targeted relief. Non-pharmacologic techniques like acupuncture, physiotherapy, and chiropractic adjustments further enhance the effectiveness of pain management. The multimodal approach offers several advantages. By combining therapies, we achieve better pain control with lower doses of medications, reducing the risk of side effects. This approach also helps prevent tolerance development, ensuring long-term effectiveness. Regular pain assessment is vital. Utilizing pain scoring systems like the Visual Analog Scale and the Glasgow Composite Measure Pain Scale helps quantify pain severity. Regular evaluation allows for timely adjustments to pain management plans, ensuring optimal relief and comfort for the patient. Selection must consider factors such as the patient's age and concurrent medical conditions. Individualized care plans are developed based on the nature of the pain, patient response, and owner preferences. Collaboration with owners is crucial to establish realistic goals and expectations. Effective pain management begins before surgery. Administering pain medication preemptively reduces post-operative pain sensitivity. A combination of local anesthetics, systemic analgesics, and non-pharmacologic interventions ensures comprehensive perioperative pain control. Regular monitoring of pain levels and treatment effectiveness is essential. By using pain scales and client observations, we can gauge the patient's response and adjust therapy as needed. This ongoing assessment helps maintain optimal pain control. In a recent study, we compared the analgesic efficacy of intraperitoneal administration of bupivacaine, ropivacaine, and a ropivacaine-tizanidine combination during ovariohysterectomy in cats suffering from pyometritis. This research contributes to our understanding of effective pain management in surgical cases, aiming to improve outcomes and enhance patient comfort. The objectives of this study were twofold: to compare the analgesic efficacy of the 3 different agents and to assess their safety profiles during ovariohysterectomy in cats with pyometritis. This comparison will help us determine the most effective and safest analgesic strategy for managing pain in these surgical scenarios. We conducted a randomized controlled trial involving 30 cats diagnosed with pyometritis. The cats had an average age of 16.83 months and an average body weight of 2.59 kilograms. They were divided into 3 groups. One group received 0.5% ropivacaine with tizanidine, another received 0.5% bupivacaine, and the third received 0.5% ropivacaine alone. All cats were also given meloxicam prior to anesthetic induction. For anesthesia, we administered propofol at 6 milligrams kilogram intravenously to induce sedation and maintained inhalation anesthesia with isoflurane at a 1.58% minimum alveolar concentration MAC value. Anesthetic monitoring included electrocardiography, heart rate, respiratory rate, pulse oximetry, and plethysmography, with adjustments made based on these physiological parameters and reflexes. Pain was assessed using multiple methods: the Interactive Visual Analog Scale, IVS, ranging from 0 to 100, the UNSP Botucatu Multidimensional Composite Pain Scale, MCPS, from 0 to 30, and mechanical nociceptive thresholds, MNT, using homemade von Frey filaments. These assessments were performed at various postoperative time points to gauge pain levels accurately. Rescue analgesia was provided with buprenorphine at 0.01 milligram kilogram if the MCPS score reached 6 or higher. We recorded any adverse events such as vomiting, diarrhea, seizures, and cardiovascular issues. Cats requiring rescue analgesia or experiencing complications were removed from the study to ensure the reliability of the results. To ensure the safety of the analgesic agents used, we monitored blood glucose and serum cortisol levels, along with conducting biochemical tests for liver and kidney function at baseline, 1, 8, and 24 hours postoperatively. In the results section, we first observed the intraoperative variables presented as box and whisker plots across the 3 experimental groups: RT, ropivacaine tizanidine, B, bupivacaine, and R, ropivacaine. Panel A shows the average duration of anesthesia, revealing that all groups had similar anesthesia durations with no significant differences noted. Panel B depicts the duration of surgery, which was consistent across all groups, indicating that the choice of analgesic did not significantly impact surgical time. Panel C illustrates the extubation time, where the ropivacaine group R had a significantly shorter extubation time compared to the other groups, suggesting a quicker recovery from anesthesia. Finally, Panel D presents the recovery time, showing that the RT group had a longer recovery time compared to both the bupivacaine and ropivacaine groups, indicating that adding tizanidine to ropivacaine may prolong recovery, a fact to consider in postoperative care. Similarly, Figure 2 examines changes in physiological parameters before and after surgery across the 3 groups. Body temperature remains stable across all time points and groups, with no significant deviations postoperatively, reflecting effective thermal regulation. The pulse rate showed minor fluctuations postoperatively but stayed within normal limits across the groups, suggesting stable cardiovascular function. Respiratory rates were slightly elevated immediately after surgery but returned to baseline levels, indicating good recovery of respiratory function. Systolic pressure initially increased following surgery, particularly in the RT, before stabilizing, which is a typical response to surgical stress. Overall, these parameters underscore the physiological stability of the patients, with effective pain management contributing to a smooth recovery process. Figure 3 illustrates postoperative pain scores measured using 3 scales: the Interactive Visual Analog Scale, IVS, the Modified Composite Pain Scale, MCPS, and the Mechanical Nociception Test, MNT. Panel A shows that the RT group exhibited consistently lower pain scores compared to the B and R groups throughout the postoperative period, with significant differences at several time points. Panel B demonstrates that the RT group had superior pain control according to the MCPS, especially during the early postoperative hours, highlighting the efficacy of the RT combination in managing pain. Panel C presents MNT results, indicating that the RT group had higher nociceptive thresholds, reflecting better analgesia and reduced pain perception compared to the B and R groups. These results underscore the enhanced analgesic effect of the ropivacaine-tizanidine combination in providing significant pain relief during the critical postoperative period. Figure 4 presents postoperative levels of stress indicators, including serum cortisol and plasma glucose concentrations across the three groups. The RT group showed significantly lower serum cortisol concentrations postoperatively, particularly at the 1 hour and 8 hour marks, indicating a reduced stress response compared to the B and R groups. Plasma glucose concentrations were also lower in the RT group at all postoperative time points, suggesting that the RT combination not only provided better pain management, but also mitigated the physiological stress associated with surgery more effectively than the other analgesic agents. Figure 5 assesses postoperative values of key liver and kidney function indicators. The levels of aspartate transaminase, AST, alanine aminotransferase, and alkaline phosphatase, ALP, did not show significant increases across any time points, indicating that none of the analgesic agents caused notable hepatic stress or damage. Similarly, BUN and creatinine levels remained stable postoperatively across all groups, suggesting that the analgesic treatments did not impair renal function. These findings suggest that ropivacaine, bupivacaine, and the ropivacaine-tizanidine combination did not result in significant hepatic or renal adverse effects, confirming their safety for intraperitoneal analgesia in cats. Finally, Figure 6 presents a pairwise analysis of biochemical parameters within the RT group using Dunn's multiple comparisons test. This analysis includes parameters such as AST, ALT, ALP, BUN, and creatinine levels. Dunn's test allows for a detailed examination of parameter changes over time within a specific group, controlling for increased type 1 error risk from multiple comparisons. The analysis revealed no significant fluctuations in the levels of AST, ALT, ALP, BUN, or creatinine over time. In conclusion, administering ropivacaine-tizanidine to the ovarian pedicles and uterine body after excision resulted in effective postoperative analgesia. Further studies are needed to explore the full potential of tizanidine as an analgesic treatment in cats. Looking ahead, emerging therapies and technologies in pain management offer exciting possibilities. Research into new drug formulations, gene therapy, and non-invasive pain relief techniques may revolutionize veterinary pain management. It is essential to balance pain relief with overall quality of life, and effective interdisciplinary collaboration will be key to achieving the best outcomes. Thank you for your attention. By adopting a multimodal approach, we can significantly enhance the quality of life for our patients, providing them with the best possible care.